Welcome to EmCyte's webinar series. Join us as we explore the latest clinical insights and the science behind precision biologics.
Good evening, everyone. Good evening in the audience, for the audience in the US, East Coast, West Coast, and also good night for our audience from the European countries. I know a couple of our audience now from the Europe, and also good morning to our audience from the West Asian countries, specifically my country, Iran. Welcome to the EmCyte Regenerative Edge webinar series, and I'm truly glad to have you with us tonight as we continue building this space for meaningful conversation around the regenerative medicine. This series is all about the looking beyond the obvious challenging assumptions, sharing real world insights, and advancing our clinical outcome through the smarter, more personalized approach. Tonight, we are joined by Dr. Ron Paul, one of my best friend in the Regenerative Society, and it's my absolute pleasure working with Dr. Paul closely, a respected leader in the sport medicine and regenerative medicine. He'll be sharing his clinical experience on how commonly prescribed medications can impact PRP result, something we often overlook, but it's incredibly important in daily practice. And then after Dr. Paul, I'm gonna start talking around 20 minutes, 15, 20 minutes about the general aspect of the PRP, but specifically some variables. Usually we consider them as silent variables, and sometimes we don't consider them very seriously, but tonight we are gonna find those silent variables very important for the outcome of our practice, specifically when we use the PRP for regenerative medicine. And as we go at the end of the webinar, we have the question and answer session, and feel free share your thought, questions through the chat, and we're going to discuss at the end of the presentation. So with that, Dr. Ron Paul, feel free to say hello and welcome to the board. And we are all here to listen and to receive all of the great experience regarding to the regenerative medicine and your daily practice with us. Thank you so much.
That's so sweet. Thank you for that kind introduction, Sina. It's been a pleasure so far and excited for more. So this is a kind of important topic for me, and anyone in the audience who's a clinician and actively treats patients with PRP, MSC type treatments, bone marrow fat. I'm going to focus primarily on PRP for this one, but I'm going to go ahead and share my screen, and hopefully this will work. Okay, so we're going to be talking about, some of the silent variables and how to improve your outcomes, specific to apart from the platelet. And I kind of wanted to talk a little bit about cells and wound healing and matrix formation, because I think it all starts from the basic science. And if we have a reasonably good handle on that, we'll understand why we have to hold the medicines and supplements that I'll talk about. So these are my disclosures. So healing is actually quite a complex orchestra, symphony of different cells and growth factors and cytokines that come together to help us heal. So we're going to go over a musculoskeletal injury and the body's natural healing response. We're going to talk about a multitude of factors beyond the platelet that affect tissue regeneration. We're going to talk about the interconnectedness of inflammation, cell recruitment, matrix deposition, and remodeling. And then we're going to talk about the effects of NSAIDs on orthobiologics, as well well as some common supplements and orthobiologics. So mononuclear leukocytes are really the orchestrators of early healing. Monocytes, macrophages, lymphocytes, and they help with phagocytosis of debris and pathogens, help with secretion of cytokines, growth factors that modulate inflammation, help with recruitment of other cells, including fibroblasts. And they help transition the cell environment from a pro-inflammatory to an anti-inflammatory phenotype, which is crucial for healing progression. And it functions along with MSCs with a paracrine effect. So you get trophic effects, immunomodulatory effects, antimicrobial effects that restore the natural environment, resulting in a functional remodeling, contraction, proliferation and migration, hemostasis, pro-inflammation, and angiogenesis. So collagen is super important, right? So the fibroblasts are the collagen architects, and effectively, fibroblasts are the primary cells. Growth factors and cytokines recruit them to the injury site, and that results in a pro-collagen synthesis and its extracellular processing into collagen fibrils. So transcription and translation from the ribosome results in hydrolation and glycosylation of proline and lysine residues. That gives you a triple helix formation, secretion of procollagen in the extracellular space, cleavage of propeptides by enzymes, self-assembly of collagen molecules into fibrils, and then collagen cross-linking. And this is, I think, the most important step, the collagen cross-linking, that can result in good healing, slow healing, excellent healing, biomechanical strength and resilience. And this is where we can really start affecting our outcomes. So the collagen maturation and cross-linking process is super important. And a main enzyme is lysyl oxidase, or LOX. And it's super important to this tensile strength and stability of healing tissues. And we know that collagen maturation can take months to even years. Jane Fitzpatrick just presented at the Biologic Association on gluteal tendon improvement on MRI even 7 years later. So loss can be affected indirectly and directly by NSAIDs, supplements, peptides, and nutrition, and that may affect healing. So we'll talk about nonsteroidals. So obviously we have non-selective nonsteroidals like ibuprofen, naproxen, diclofenac, indomethacin, that kind of thing. And there's some studies that show that this actually may delay wound healing, particularly in the early phases, by inhibiting inflammation, which is crucial for cellular recruitment, like MSCs, and as well as macrophages and matrix deposition. And this results in reducing fibroblast proliferation and collagen deposition. And so their short-term use is probably okay, maybe less concerning, but the problem is we don't really know what the threshold is, both for dose as well as duration of use. Tendon healing, we know that it inhibits tendon cell proliferation and migration, and this may potentially affect the early stages of repair. And some studies show increased collagen synthesis, but the biomechanical strength is decreased. So joint healing, we know the long-term use of nonsteroidals results in collagen breakdown, including articular cartilage, by inhibiting chondrocyte proliferation and matrix synthesis, and this may inhibit bone healing in the joint. How about the partially selective nonsteroidals? So these would be like celecoxib or Celebrex, even meloxicam is considered this. They don't typically significantly affect platelet aggregation or adhesion or degranulation in studies, but they do still affect the prostaglandin axes of inflammation. And this may impair bone and soft tissue healing, potentially even more so than non-selective nonsteroidals in certain contexts, like bone healing. So there's really no consensus yet on tendon and joint healing, but I would just exercise caution when using nonsteroidals, especially the COX-2s. So general considerations is I have people avoiding all nonsteroidals, COX-1 and COX-2s, as well as aspirin. I do actually hold Tylenol now as well, because at high doses that can affect platelet aggregation as well. And I avoided a week before and for the first 3 weeks after which I do let some people in a limited fashion and on a case-by-case basis use the lowest minimally effective dose, particularly if it helps to allow earlier rehabilitation. I do tend to favor meloxicam and Celebrex over the COX-1s based on what I just talked about. And I would just say, as a summary, there's direct and indirect variables affecting immunomodulation, tissue regeneration, and biomechanical properties. We know that nonsteroidals can provide pain relief, but their potential negative effects on tissue regeneration should be carefully considered, especially for long-term use. So how about nutrition, right? We are what we eat. We feel what we eat. I've posted a lot about this on LinkedIn. Microbiome matters, right? And we know that nutrition affects LOX, that ultra important enzyme that affects collagen formation and cross-linking. So I encourage copper-rich foods like shellfish, nuts, cashews, seeds, and whole grains. I talk about vitamin C sources, preferably in the diets with citrus, berries, bell peppers, and leafy greens. But if they don't have a great diet, I do tend to say, supplement with vitamin C. Bone broths have a lot of collagen precursors and amino acids like glycine and proline, which contribute to collagen formation. Egg whites are rich in proline as well. And then garlic has some sulfur compounds that support collagen production and affects LOX directly. Now, if someone has a terrible diet and you just know they're not going to be around to cook and be healthy, and there's no one around to help them, I actually get people on Prolon. If you look that one up, that's actually meal prep, and it's very similar to this. It gives you kind of all of these, substances and, fairly low carb. And what's interesting is people lose a lot of weight actually. And so I started a week before and recommend 3 weeks after. How about supplements? Well, there's really not a lot of studies that I could find on orthobiologics and supplements themselves. There's a lot on longevity, on inflammation, and so I'm sort of interpolating a little bit here. I will say that individual responses may vary by supplement. There's a huge variety of quality of the same supplement on the market because of poor regulation. Dosing and timing is certainly not established, and so we just have to proceed with caution. Doesn't mean it won't help, but a lot more study needs to happen. So the supplements that I talk routinely to my patients about are omega-3 fatty acids, which reduce inflammations. And I start at 5 days post and I hold it 3 days before. So it's primarily for bruising risk. Similar with curcumin, turmeric stimulates collagen synthesis and protects collagen fibers from oxidative stress. And I start that about 5 days post because, again, I don't want to blunt that acute inflammatory stage. Vitamin C, cofactor for enzymes to stabilize collagen. I start it a week before and continue for a long time on this one, 4 months after. Zinc, cofactor for collagen synthesis and protects against degradation. So again, I start that a week before and 4 months after. Vitamin D3, lots of people are low in vitamin D, and I always ask this in my initial intake consult. And a lot of people are like, oh yeah, I'm in the low 20s. That's not enough. Even 30 is not enough. And so when you look at some of these athletic articles, particularly for stress fractures and tendinopathy, we kind of want them above 50. So I have a very low threshold for putting on people on 5,000 IUs per day, knowing what the baseline vitamin D is, and then recheck in 3 months and make sure they're not toxic. Collagen peptides like BPC 157 and TB 500. You'll hear a lot more of that if you're not already. Be careful with your states. Some states don't allow the physician to administer it. There is an oral form of these two peptides, which can be quite helpful. L-arginine, which is kind of an ergogenic for exercise, helps certain microcirculation. BBC we talked about. Resveratrol, nicotinamide riboside, which is an NAD precursor. Quercetin, very interesting substance, anti-aging, sirtuin-1 influencer, betaine, and resveratrol. And then urolithin, which is basically helps, or might appear as a brand, helps with mitophagy. And so I'm starting to talk a lot more about how do we energize the healing engine of the body. You put your platelets in, it takes a tremendous amount of energy to actually then follow through with a good healing cascade. And so I try and energize with various things such as these supplements, photobiomodulation, shockwave, that kind of thing. So for me, immediately after my procedures, I am treating with the MLS laser and EMTT. I have people work with red light therapy at home, and even a hyperbaric oxygen. Again, we just have to energize the system, and that can help with healing. But remember that we have to be clinicians, and not all of these treatment are needed for everyone. So we have to be clinically precise. So that's about it. Thank you so much.
That's great. Thank you so much, Dr. Paul. Very, very informative and very dense. So also, I'm going to talk about some of the stuff you already talked, but my consideration is mostly for the diet. Already our patients are already on those diet, and before drawing the blood and preparation, the PRP, and how these supplements or diet can affect our PRP outcome and PRP function. So we can discuss more after my presentation. Maybe at some point we don't have disagreement on that, but maybe we need to make it more clear for our audience, specifically regarding some vitamins like vitamin E and vitamin C. I totally agree for regeneration. We need the vitamin C for collagen synthesis, but if we go for the vitamin C as our daily vitamin supplement for a long time before drawing the blood and PRP, it can affect somehow the platelets aggregation and activation. So we need to talk, and we need to go for more details. And so, yeah, we are going to talk about that. So let me check the. Okay, we have our questions through the chat. Please send a question through the chat. Dr. Paul, do you have access to the chat panel?
I think I do.
I think you should.
Yep, I agree with BIM, BPC 157. That's a really good point. If you're treating competitive athletes who are being drug tested, absolutely, we have to be careful with BPC. And I think TB 500 is being considered as well. Yeah, that's a good point.
So if you agree, our audience, we can start. I can start my presentation, and hopefully I could be done in 15 minutes, 20 minutes, and then we could have more discussion through the question and answer session.
Sounds good.
Okay. So you have my screen now?
Yep, we can see it.
Okay, great. Thank you so much again, Dr. Paul. And thank you so much, everyone, for joining us. So tonight, I'm going to talk a little about the silent variables with the load outcome on our PRP outcome and PRP therapy outcome and results in the clinic. So, okay. So my outline is going to be, I'm going to talk about the patient baseline blood, which is very important. I'm going to start with the very simple parameters we need to consider in our practice. Unfortunately, only in the MSK Society, we mostly check the details of the baseline, but for other fields, still we need to work on it, and we need to consider different parameters, not just preparing the PRP and use the PRP, because tonight we are going to find that how important some very small and tiny factors for the outcome of our PRP. So we're going to start with the patient baseline, very simple, and then lifestyle and some factors like diet, supplements, medication. Already Dr. Paul talked about that. And after that, we are going to talk about some other factors during the preparation of the PRP and how they can influence on the outcome and function of our PRP. So my disclosure, I'm the scientific director of the EmCyte, so it probably I do have a potential conflict of interest, but our goal today is to support open scientific discussion. This content is educational and not intended as medical advice, at least my content. So I'm not a physician. You know about the PRP. We use the PRP in our practice at the different field of the regenerative medicine, because it's enriched with different growth factors and cytokine. I named the main player of the PRP 10 years ago as a brainless genius, which is depleted without a nucleus, but it acts very, very intelligent, and it has different types of the growth factor can release and cytokines, and it provides us in the PRP two different functions. it could be pro-inflammatory and inflammatory biologics, and it could be anti-inflammatory biologics. So when we want to use the PRP, we need to consider these dual function and dual role, and then based on our aim and purpose, we could manage how to use the PRP and how to enhance and boost the outcome using the PRP. So the general concept of the PRP using the centrifugation technique is separating the different component of the blood, specifically isolating and recovery the platelets as a main player and other cellular components like leukocytes from the blood, but discarding and excluding the red blood cell, which is not a good guy for the regenerative medicine. And then today we have different kits in the market and different techniques to recover the cellular component of the blood. And in the general, we name them as a PRP. And so you know the PRP better than me today. So I talked about that. Before anything else, we need to define the primary purpose of the using PRP for our practice, for our goal. If is our goal regeneration, inflammation control, or both? This first step is essential because it shapes everything that follows the PRP formulation, delivery method, and even the treatment frequency. This function, the regeneration and inflammation modulation are not mutually exclusive, but their dominance depend on the several factors. Could be based on the composition of the PRP, including the leukocyte content, proteins, and activation state. And also it can target different tissues. Based on the different tissues and based on the different aim, we could control and a little manipulate the formulation of the PRP, and also the dose and delivery method is going to be very important when we decide for what indication, for what pathology, and for what aim we are going to use the PRP. So as you can see in this cartoon, PRP can provide us both anabolic and catabolic cytokines and growth factors, and we can decide which feature we are going to use, and then by some manipulation we could more redirect the PRP toward that purpose, because at some point regeneration and anti-inflammatory treatment is going to be in conflict to each other. So based on that, we decide to have which one, and then we could include some of the components more like leukocyte, or some of them less in our formulation. So you definitely heard about the inconsistency in the outcome of the PRP, even when we keep some of the parameters and factors in our PRP same. For example, even if we use the same dose of the PRP with different technique and different kit, but sometimes we have inconsistency in our practice, and why it happens. So it depends to some other parameters sometimes we don't consider that. For example, blood pressure. So we have hypertension and we could have the acute blood pressure. So how many of us, when we want to do practice or we want to do treatment with the PRP, check the blood pressure before drawing the blood, and we'll follow the blood pressure of the patient? Because definitely when we have hypertension, it can affect on the quality of the platelets, and it changes some parameters of the platelet like MPV, MPM, and MPG. Hypertension can somehow prepare the platelets to be more close to activation, and at some point maybe they can be activated in our peripheral blood, and they already release some of the useful growth factors. We need them for regeneration, and when we draw those platelets from the systemic blood through peripheral blood and prepare the PRP, we don't have that enough growth factors or cytokines we need, because we don't we didn't have the neutral and healthy platelet in our PRP in our body. So one of the important things we need to consider, if our patient is suffering from the hypertension or even acute blood pressure, we can check before drawing the blood for to make sure everything is in the normal situation and condition. So another thing is the supplements and medication, and Dr. Paul already talked about some of the factors that can, some of the medications we already check in the practice and the clinic to make sure we don't have any conflict or contradiction using those medication. But some of the supplements and some of the foods and diet also can influence and affect on the properties of and function of the platelet in the body. For example, if we use a lot some of the specific supplements like omega-3, so definitely omega-3 with the dose over 600 milligram to 6,000 milligrams for a long time, although it's very useful and good for overall health and cardiovascular disease, but it can affect on the platelet and reduce the potential of the platelet to be activated. What does it mean? When we want to use the platelets in the PRP, after injection of the PRP, we want the platelet to get activated and release the cytokines and chemokines, growth factors upon the degranulation. But when we are on the diet with some specific supplements like omega-3 for the long term, already they affect the platelets, and our platelet won't be that sensitive to get activated after preparing the PRP and injection, the platelets. So it's better if we want to do practice, if we want to draw the blood and prepare the PRP from the patient already, they are taking the omega-3 or vitamin C with the dose over 1 gram per day, or vitamin E, which is another good supplement for the overall health. But if our patients already taking the vitamin E over 3 months with the dose over 300, it's better to stop these medication, these supplements, at least 2 weeks before drawing the blood, because when we have the patient with these supplements or medication, definitely the quality of the platelet significantly less than the quality of the platelet when we have on the patient without these supplements. Another one is the magnesium, and magnesium also with the dose over 800 milligrams for more than 3 months can reduce 30% to 40% of the capacity of the platelet for aggregation and activation after injection through the body. We still have high number of the platelet if we go for the high dose of the platelet, but assume 40% of our platelet cannot be activated anymore, even when they are gonna exposed with the collagen. About the diet, so one of the things, again, we have different types of diet, and we are gonna follow the healthy diet like Mediterranean diet, or using herbal-based diet. But in overall, for the health, they are going to be very, very good and useful. But in the case of PRP and drawing the blood for PRP preparation, if we use a high amount of the dark chocolate, definitely it affects the PRP activation potential. So without PRP activation potential, we definitely have less amount of the growth factors and cytokines and any all of the regenerative stuff we need from the PRP. Another one, it's the nitrate-rich food like radish, like beets. So most of our patients in the elderly age, they are using beet, or they're using garlic or something like that for their cardiovascular health, which is very good, but some essential molecules in these specific food or diets, they can affect the PRP function regarding to activation of the PRP and release the cytokines and growth factors. For example, in the garlic, definitely allicin of the garlic can, and other sulfur compound can inhibit the platelet activation after injection, the PRP. So I know some specific countries, they have garlic in their regime, in their diet. So it's better to keep in our mind when we want to use, when we want to draw the blood for the PRP preparation, at least ask our patient to stop 2 weeks in advance. Why 2 weeks? Because mostly in average, our body can replace the platelets every 8 to 10 days. And the optimum life of the platelets in our body is something around 10 days. So we say 14 days just in case, to make sure when we stop the medications, when we stop the supplements or any diet. So after 2 weeks, we have mostly our new platelet without any influence of these specific diets or supplements. Another one is the alcohol, and caffeine. If we are using lots of the caffeine or alcohol or sugar, definitely they can affect on the 50% of our platelets. So we need to consider: do we need just quantity of the platelet, or we need to consider quality of the platelet? Something very, very simple and very small that they can make the big difference at the end of the treatment as the outcome of the PRP therapy. So exercise. So one of the trick we could use to increase the platelet number is the exercise. There are some studies, they showed if we have moderate exercise for a long term, it can be helpful to increase at least 7% to 18% of the number of the platelets. But recently, one study showed even if we have very intense exercise to reach 100% of our cardiac capacity, VO2, for 4 minutes, for 5 minutes, we could increase the number of the platelets by 35%, which is very good. And also we could increase the growth factors, one of the essential growth factors, TGF-beta, just with short, intense exercise. In the case of when we have patients with a low baseline of the platelet, we could do some trick like this to increase the number of the platelets at the baseline of our patient. Another thing I'm going to talk a little about during the preparation of the platelet, one of the things we need to consider is using the anticoagulant. What types of anticoagulant we are going to use? Most of the market available kits, they provide the different anticoagulants, and so each of them have advantages or disadvantages. So regarding to the anticoagulant, the famous one is those 4 anticoagulant we know as heparin, ADTA, ACTA, and sodium citrate. So today we have kind of consensus about the avoiding using the EDTA and heparin. So EDTA can change something irreversibility about the calcium signaling and calcium flux through the platelets. It's very, very strong calcium chelator, but when we use the EDTA, sometimes after preparing the PRP, even when we recalcify the PRP and exposing to the collagen, we don't have that level of the activation which is desirable for us. So that's why we cannot trust on the EDTA. Same regarding to the inconsistency, we saw that when using the heparin, we don't recommend using the heparin. And today in the market, most of the kits are going to use citrate or ACDA. But one of the question, which one we should use? Mostly based on the literature, ACDA, when we use the ACDA, since it's more acidic, the recovery rate of the platelet is going to be more than citrate. But there are some consideration and concerns around the citrate. Based on the reports in the literature, when we use the ACDA as anticoagulant for our PRP preparation, at least 3 times by 6 times, we have greater level of the glucose at the baseline of our blood. So what happens when we have that level of the glucose, high level of the glucose? When we inject the PRP, we are going to create a kind of local diabetes for our injury site. So definitely that high level of the sugar, high level of the glucose can affect the angiogenesis properties of the PRP. If you remember our conversation from last webinar in the Toby, I talked about the angiogenesis, which is one of the most important function of the PRP. When we use the PRP for regenerative therapy, for regenerative medicine, we need to have the angiogenesis. In the 99% of the cases of regeneration, we need angiogenesis. Only in the 1%, maybe we don't need that angiogenesis. So, and PRP started its duty with this function. So if we kill this function, so what? What we can get from the PRP if we don't have the angiogenesis? There are lots of studies, molecular mechanism, and in vitro, in vivo study. They showed that at the high level of the glucose, we definitely hinder the function of the VEGF, which is the most important growth factor regarding to angiogenesis, and then we increase the apoptosis. So if we want to use the PRP for regenerative medicine, we need to consider this tiny things regarding to the preparation of the PRP, but we can find that tiny things can change it very, very big and significantly difference of the outcome. So we have a couple of the studies and the reports in the literature that they found that when we have high level of the glucose, it doesn't affect just on the platelet, it also affects on other cells. For angiogenesis, we definitely need to recruit the endothelial cells, and one of the function of the platelet is recruiting the other cells, stem cells and endothelial cells. So for angiogenesis, the most important function of the endothelial cells is tube formation. With high level of the glucose, we stop the tube formation, we stop the cell migration, and we don't have any angiogenesis sprouting, and we don't have angiogenesis consequently, we don't have vasculogenesis. So we need to consider that. There is a study regarding to the in vivo using the ACDA and comparing the ACDA with the sodium citrate, and sodium citrate when we have just bare sodium citrate and when we add the glucose to sodium citrate. You can definitely find that in these cartoons when we use the sodium citrate alone for our PRP preparation after 6 days, we almost have a kind of more than 60% wound closure. But in the case of ACDA and other treatment or other preparation using the glucose, we won't have any effective wound closure. And even if you look at the histology pictures, you could see how organized collagen structure on the case of the PRP prepared using sodium citrate versus the groups we use the PRP prepared by the ACDA, and we have significantly high level of the immune cells infiltration in the case of PRP treatment with the ACDA prepared PRP compared to the sodium citrate prepared PRP. So we also check that in our laboratory here with one of our competitors with the same recovery rate in the market. We are using sodium citrate and they're using ACDA. And if you look at this result, you could find after preparation of the PRP, we could keep the level of the glucose as a baseline because when we draw the blood, we use that blood to test the pH, and then after preparation of the PRP, again, we use the PRP to check different parameters, and you can see EmCyte system can keep the glucose level as a normal, but another kit with the ACDA can increase the glucose level at least 5 times, 6 times more. So still, we have same number of the platelets, same deliverable dose, but different glucose level. So definitely we have different outcome, even with one tiny variables. About the activation or not activation, there is lots of disagreements. But we need to consider that, again, what purpose and what aim we are going to follow using the PRP. If we want to have immediate release of the cytokines, maybe we need to activate prior injection, or even using calcium as a kind of pre-activation. It depends to the concentration of the calcium we are using. If we use the calcium less than 4%, it's going to be mostly recalcification. In most of the case, we don't need that because 4% provide us 10 millimolar calcium, but we need only 2 millimolar calcium as a physiological calcium level. And upon the injection, the PRP platelet can receive that, uptake that from the tissue. But if we want to accelerate the activation, we could add 4% calcium. Again, if we don't add the calcium, it won't be any problem. And we mostly suggest for musculoskeletal regeneration, clinical application, and knee osteoarthritis, we don't need to add calcium. And upon the injection, PRP can receive that calcium within the tissue. And for some other applications like skin treatment and microneedling, when we need to immediate and burst release of the cytokines, maybe we could use the activation in advance. Or in some case, like wound healing, wound dressing, when we need to have the scaffolding, yes, we can use the high level of the calcium, maybe 10% of the calcium. In this case, calcium gluconate is better than calcium chlorate, which provides us more release of the growth factors. And also we could use some other activators like thrombin instead of the collagen to make the scaffold. And one thing we need to consider when we activate our PRP, when we prepare our PRP, we need to consider our growth factors half-life is very short. Based on the literature, in most of the cases, in 90% of the cases, when you read the literature, they say, okay, upon the activation, gradually we have more and more and more and more growth factors, and the trend is increasing. But the thing we need to consider that with the current available techniques to measure the growth factors, yes, which is true, the trend is increasing, but who guarantees if we have the bioactive growth factors? If you look at this chart for VEGF, we have half-life something around 20 minutes, 30 minutes. For TGF beta, we have half-life something around 3 minutes. So we need to consider if we activate PRP for injection, we need to inject it immediately if we want to get the benefit from the TGF beta or other growth factors. But some case, we don't need to get the benefit from TGF beta. And even the presence of the TGF beta is going to be a kind of, it's going to be detrimental for us. So on that case, maybe we could do some trick, activate in advance, and then inject our PRP 10 minutes later. So with consideration of these tiny variables and factors, we could manage and manipulate our formulation and toward the best outcome of the PRP. And the last things I'm going to share with you regarding to the preparation technique and preparation setup. We recently worked on the technique, on the preparation technique design, and we ended up with a new not new design, new upgrade of our current design, which is going to be released in the market in a couple of weeks. So now we can offer PRP kits with over 90% recovery as monocyte-rich PRP, but still neutrophil for PRP. And for the totally leukocyte for PRP, we are going to have over 87% recovery. So why I brought that? Because one of the variables we can consider is how we are going to set up and how we are going to design our technique for preparing the PRP, and it definitely influences on the outcome of the PRP. So still, there is a question, is all PRP the same? Definitely no. We have different variables in our PRP. And one thing we need to consider that the term of standardizing the PRP is the wrong term. We need to consider that since there are lots of different variables and it's a kind of personalized biologic with the source of the human. So we need to consider that as a personalized PRP eventually rather than a standardized PRP and formulation. And thank you for your attention. This session is the first session of our webinar in the EmCyte as a regenerative edge, and we are going to have monthly webinar, and the next one is going to be what, when, and where, choosing between the PRP, fat, bone marrow, and A2M, combination of them based on the different criteria and consideration factor. And the time is next month, June. You can see the time in the screen. And we are going to talk about different important factors we need to consider to enhance our practice. So thank you for your consideration. Now I think we can go for the question and answer session, if you agree, Dr. Paul.
Yeah, I'll get the ball going as people are thinking about questions. But I have a question for you, Sina. Like you mentioned vitamin C, obviously, and my understanding is that there's a dose dependency on its effect with platelet aggregation and degranulation. And then if you could talk a little bit deeper onto like when would you allow people to take it, particularly because it helps with collagen synthesis and cross-linking at certain doses. So for me, I don't start it until about at the earliest day 5. Pretty much all my supplements, I don't really start it until day 5.
Oh, yeah.
A lot of times it's even 2 weeks. So
yeah, before drawing the blood, I would suggest 2 weeks before drawing the blood, we need to stop that. And the dose of the vitamin C over 1 gram per day, it's going to be detrimental for the quality of the platelet, and it decreased the quality of the platelet at least 40%. So, but after injection, the PRP, maybe 1 week after, we could again start that, because our body every day creates over 100 billion new platelets. So, and they're continually release the new platelet, and the turnover rate of the platelets in our body is something around 7, 8 to 10 days. So after 1 week, it's going to be okay. Already the injected PRP can release everything by the most of the growth factors and cytokines by 7 days. And after that, there is no problem. We could go back toward the supplements diet we had before.
Dr. Baria published that the exercise immediately before blood draw increasing platelet count. Should we all be getting like stationary bikes in our offices and getting people to, bike vigorously for 5 minutes, 4 minutes before doing that?
So that study, the problem is the number of the cases they reported based on the number of the patient they checked. It's not that big. So the result is promising, and there are some other studies published on 2015, another one 2020, in the same trend. All of them already confirmed each other, but still we need more study to have that confidence to make it as a kind of protocol. But definitely acute exercise can increase the platelets regarding to the platelet number, but regarding to the MPV, the difference is not going to be significant. And still, there is no solid evidence behind of the role of the MPV and how MPV is going to be important, because I know there is an idea regarding to the MPV in the society, and it says higher MPV number means bigger platelets and means better platelet, but which is not true, because the bigger could be more pre-activated and already released some of the growth factors and some of the cytokines, which is essential for the regeneration. And still, there is no solid evidence around the MPV, but regarding to the dose, number of the platelet, yes. Acute, I would say mostly acute is better than the not chronic, but long-term exercise. The acute is going to be more effective for us.
Yeah, I did. When I first read that article, it was interesting, obviously. So did a little digging, and it does seem that, vigorous exercise can increase several functionality of the platelets as well as the numbers, right? So it can affect shear stresses, release of norepinephrine, epinephrine, oxidative stress, procoagulant factors. So I think there's some interesting meat there that I think should be studied a little more, maybe linked to outcomes. And I will say that, based on all the stuff that, I talked about, certainly around EmCytes and stuff, the reality is we don't have prospective clinical trials looking at this, right? What we're talking about is theoretical. And so I encourage everyone in the audience, let's do these studies. We need to find these outcomes. And it's one of the things that I'm starting to track on Data Biologics and trying to see if there's any kind of
study, Dr. Paul, some of the studies are not going to be difficult, like adding the exercise, 5 minutes exercise before drawing the blood. It's doable, and it doesn't need any specific design for that. And also, still, in other fields, not MSK, in MSK, we have that consensus about the dose, about the number of the platelet, deliverable dose. But in other fields, even they started earlier than the MSK using the PRP, still in 90% of the cases, we don't even check the baseline of the blood. So in the normal and healthy donor, we have the range of the platelet between 150 to 450. It means at this point, we have threefold differences. So assume if we have two donors, 150, one of them, another one, 350. We draw 60 ml blood using the EmCyte kit, 85% recovery. At the end, for the first one, we end up with 7.7 billion in a 7 ml PRP. And the second one, we are going to have 17 billion point 8 in the 7 ml. So you can see the difference, and even something very, very simple in some other fields, we don't consider that. And it's a time we need to consider that.
Yeah, there's, I think Dr. Mang asked a question about A2M exercising, boosting A2M in the blood because it's an acute phase reactant as well. My understanding is that it does immediately, and that is helpful, obviously, for its protease enzyme inhibitor, right? So, what are your takes on that?
Yeah, one of the consideration about the A2M, I've been asked a lot about that. When we need to combine the A2M with the PRP, when we don't need to combine them together. So the A2M is not just A2M, it's the combination of different proteins, but the most of the function of those proteins is anti-inflammatory, anti-protease activity. So if we consider the PRP for regenerative therapy, we need to accept for regeneration, we need to have initial inflammation. So if we use the A2M in combination with the PRP, definitely we minimize the inflammation. So by minimizing the inflammation, it means delayed healing, delayed regeneration. But in the case of treating the inflammation disease like knee osteoarthritis, so at this point, first of all, we need to stop the degeneration. We don't think for regeneration at this point. In this case, we can combine and we can get the benefit of the synergized benefit of the A2M and PRP. But for regeneration, I don't recommend and suggest combination because it minimizes the outcome of the regeneration if we combine them together.
So one of the things that I do in these tricky cases where we're trying to understand should we use A2M or not is there's a fact check out there, right? Dr. Scuderi developed this test way back when, and you can, if that comes back positive, for me, that is an indication to go ahead and take the extra step and process the plasma and try and hyperconcentrate, A2M. So for me, that's been helpful. But I don't know what your thoughts on that is. Should we be doing that for every osteoarthritis case?
Do the combination, doctor? For knee osteoarthritis?
Yeah, for instance, like shoulder, knee, large joint osteoarthritis, where you can get meaningful samples to do a fact check.
So, with the aim of regeneration or suppressing the inflammation, which one?
Yeah, for suppressing inflammation for like a reasonably hot joint, I think it makes sense to do it, right? So
yes, definitely.
Yeah,
definitely. But if we want to have regeneration, like acute injury, if we want to use just A2M as a scaffold, I won't recommend just A2M for a scaffold because it can affect on the regenerative properties of the A2M, on the PRP. And now there is eventually is going to be a consensus about the presence of other players like neutrophil for regeneration. And we recently heard in the society and pioneers in the society, they agree with with some of our idea regarding to the neutrophil, which is beneficial for angiogenesis and regeneration. So yeah, we need to first find the rationale behind of them theoretically, and then go for the practice to make it more solid, evidence-based solid.
Yeah, I think there's a lot of science still to be done. I think we are just scratching the surface there, and we've focused on the platelet because they're the first responders to injuries, and clearly there's a lot more data on what they do. But certainly neutrophils, monocytes, even red cells, may hold some value, right? So in certain, maybe not in crazy high concentrations. So I think we need to learn more about that over time. There's a question by Ronnie Levy. What does EmCyte have? Why does EmCyte have 20 cc vials when platelets will be so low?
Why does EmCyte have 20 cc vials?
In my understanding, there's a 30, a 60, a 120.
We don't have 20 cc.
I don't think there's 20s. I haven't seen the 20s personally. 30s, yes. Could you comment on when the 30s would be used? I hardly ever use 30s, by the way. I am like, maybe for a CMC joint, but even now, based on some of the dosing studies, I'm starting at 60 for like 99% of these joints, and then even up to 120, 180, 240 for larger joints or bilateral joints. Could you comment on when you'd use a 30 ml kit in an orthopedic case? Maybe there's a cosmetic reason for skin and aesthetics, but
yeah, for MSK, I would say we don't usually recommend for 30 ml, and because the doses matter in MSK. And even now there's consensus about the 10 billion, but I would say eventually we should go for higher, because even there are some studies, but not published yet, they mention with higher dose, significantly higher than 10 billion, they received a very, very promising outcome and long-term efficacy. So, but for a static, yes, 30 ml, it's okay. And also 20 ml, I think we do for microneedling as our gold kit, if they mention the gold kit. So for that one, since we are gonna minimize and avoid getting any red blood cells, as gonna be pure gold. So yes, maybe the platelet rate is gonna be less than others, the recovery.
Awesome. What is the ideal frequency for PRP administration? That's a good question, and I think it would depend on indication. Certainly, that might be different for tendinopathy, acute tear, acute sprain, strain, or versus chronic conditions like knee osteoarthritis. Could you comment to the ideal frequency? I can weigh in on my experience and certainly the data biologics.
My suggestion is high dose, less frequency for the MSK, because every injection definitely has a kind of injury, a second injury, and a kind of manipulation of the tissue. We are going to disturb the natural condition of the tissue. So for the frequency, if the question is, we need to minimize the dose and increase the frequency versus maximize the dose with one injection, I would say maximize the dose, one session injections. But if the question is regarding to how frequent after first we need to renew that, it depends to the responses of the body. So sometimes with one injection, there are lots of reports now. We don't need the second injection maybe by 2 years. But in some specific cases, maybe after 6 months, we need to re-inject. It depends. It's mostly person dependent. But for this first question, if I understood well, the question in the first way, I would say high dose, low frequency.
Yeah, I definitely would agree with that. There is definitely some controversy in our field, and just coming back from Biological Association, that was one of the controversies that we talked about at length. But again, 3 low dose injections to get a total over 10 billion versus 1 over 10 billion for a large joint, for instance. I think for me, it's a practicality thing and it's a cost thing too, right? So like if you're bringing patients back for 3 PRP injections, yeah, your bottom line is going to be higher from a revenue perspective, but you're also not giving patients the platelet per dollar value that I think they deserve. And so for me, plus you're increasing their risk, right? Every time you put a needle into a joint, you're increasing the risk for infection, right? And scarring and adverse events. And taking time out of their schedule because there is some recovery time for what they can do. So for my patients, and I have a lot of people that fly in, like they just want one-hit wonders and kind of come in once a year, and that's about it. We do have some suggestion, even with some of these higher doses. It's a trend. I wouldn't say it's something definitive, but there does seem to be a slight drop off after about 6 to 9 months in their Coos Jr. and Who's Jr. In the data biologics registry. So I am starting to really track on that. And as soon as I start to see their functionality scores start to drop even a little, I bring them back and I do a booster. And again, I would still do a high dose at that time. So
yeah, that's great. So I think it was the last question, and thank you so much, everybody, and for joining us for the first session of the Regenerative Edge at EmCyte webinar series. And we are going to be very happy, and we are very welcome if you share with us your suggestion, your thought through the email webinars, EmCyte webinars. That email, you already received the link for the future topics. We can provide the future webinars based on your request and your suggestion, based on the demand and need in the society to cover more factors, more angles and perspectives of the regenerative medicine. Again, thank you so much, Dr. Paul, for taking your time and joining us. And if you have any final summary for us, we are going to be happy to hear.
Yeah, I mean, nothing crazy. I mean, thank you so much for inviting me. I think that was a really interesting discussion, and just shows how dense a topic it is. And we could talk for days about it. But for those in the audience, just I think the take home points are there are variables beyond dose, beyond volume of blood drawn that can positively or negatively affect your outcomes. So we really need to be thinking like physicians and clinicians when we're talking with patients, and that has to start on day one on the consult. It can't be. It's too late if you're talking to them on the procedure day. So that I think has to be worked into your system. So get handouts for your patients immediately on the day of the consult. Make sure you're asking the right questions if you're planning on doing a PRP on the day of the procedure, a day of the consult. So many times you'll ask them like they've been on blood thinners, or they've been on NSAIDs, or they've had 3 coffees already that day, or they got they had drank 5 glasses of wine the night before, and so that's definitely going to affect their outcome. So I think, make sure you're asking those questions. If you're using a biologic, orthobiologic like PRP, we really need to be asking those questions. So that's all. Thanks for coming.
Yeah, thank you so much. Stay tuned. So we are going to see you soon with our second webinar. You have a wonderful night, and for our friends from the countries, wonderful morning.
Thanks.
Bye for now.
Take care.
Thank you for joining us in this session of EmCyte's webinar series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.